To raise new questions, new possibilities, to regard old problems from a new angle requires creative imagination and marks the real advance in science. I put this is good for dentistry because it shows the innovation and passion that dentists have for their patients and for solving problems. It all started at Dallas post-polio patients in the Dallas Rehabilitation Institute back in 1993. Dr. Joe Verislav was the physician there, and he was having problems with his post-polio patients who are basically paralyzed from the neck on down. Helping him breathe at night, he reached out to Dr. Jameson, a sleep physician, and he was working with these patients, and his sleep tech, Sue Sorter, was as well. Sue had met a dentist who she thought might be able to help them. His name is Dr. Keith Thornton. So she reached out to him because he had just invented the tap appliance, and she knew about that. And so she asked Keith if he could come over and see what he could do for these patients. See, these post-polio patients had challenges at night. They have challenges during the day. They can't breathe without assistance. They're on a ventilator, and ventilators have pressures up to 65 centimeter water pressure. And remember, CPAPs only go to 30, so CPAPs could not be used for these patients once they go to sleep. There's no mask that could hold that much pressure. Sue is working on a mask to try to hold it to the face strong enough so that the 65 centimeter pressure would not leak, but very unsuccessful. So these patients can't breathe without assistance, and of course, CPAP is ineffective. So Dr. Thornton came over and looked at the situation, and he thought that he came up with the idea to attach a mask to his tap device by face impression of the patient, and then that mask could then be attached to the ventilators. Well, by doing this, he was able to stabilize the mandible, keep it from moving around, and eliminate the straps and the leakage, both of which were big issues for these patients. So Keith told me that he was determined at the time that he could not only improve the mask that Sue brought in, but he could improve the whole technology using dental techniques. And that would be the oral devices that we could attach to it, and also the little blue nut that he took off his face bowl. So don't throw those face bowls away. You never know when they could come in handy. And I'll show you what the blue nut is in a minute here. So this is Dorothy, his first patient, and I actually got to meet Dorothy. She is an extremely sweet person. It's just sad that she has to be on this situation, but this is her in her wheelchair with a ventilator behind her, and I'll show you another picture of that. But the ventilator produces 65 centimeter pressure that goes up into here, and during the day they hold it. Like she's holding her breath right here, and in her hand is the hose, and so she could take it in and out during the day, but at night you can't hold it in. So this is the mask that Dr. Thornton made her with the blue nut. I'll show you a better picture here. This is Deborah, which I never met, but this is the ventilator behind here, you can see, and then the hose goes one to four and up into here. And this is the close-up of Deborah. This is the mask that Keith made at the time. This is the ventilator hose. This is the blue nut. They took off his Facebook technology, connected to the oral device through a post here. So that sealed them off and allowed the air pressure going through the nose. The challenge was, how do we take a face impression? And so Keith thought of putting these patients in iron lungs, which back in the 50s, that's everybody has an iron lungs. With ventilators, these have not been used anymore, but hospitals have them. So he went up to the hospital and put this lady in the iron lung, and this is a ventilator hose, which they could take off because the lung would breathe for her. Okay. So I had the opportunity to help Keith take impressions on a lady. Her name is Judy, and she needed a new custom mask made because she wore out the other one. In fact, that was Judy in the previous picture 25 years before. And we put her in the iron lung, and she started to actually cry a little bit. And we said, "What's wrong?" And she goes, "Well, last time I was in the iron lung, my mother was not the last time. I remember as a child when my mother would see me in the iron lung, was just be in a corner crying." So she has had this for a long time, and she got over it, and she got in there, and we were able to do a face impression because now the lung was breathing for her. She didn't need a ventilator anymore. So while we were out there, this is Dr. Thornton, by the way. This is the respiratory therapist, and this is me. I said, "Can I get in?" I thought, what other possibility would I ever have to do this? So I got in there, and they strapped me up, and I started to count backwards from 100, and pretty soon I was counting, but no sound was coming out because the lung was breathing for me. Really weird experience. This was their world. This is what they could see. This is all they could ever see, and which is sad. But I'm glad they don't have that anymore. So then Dr. Thornton, after he worked out this whole technique, started working on the mask, get it better and bigger and more efficient and easier to make and more comfortable. All the things you were looking for in a mask situation such as this. And then I met him in the mid 90s, mid 2000s, and I said, "Keith, we need to get this out. This is amazing technology. This is an amazing solution to those who are really difficult." He said, I want to work on it some more. And I said, "You can keep working on it, but let's get this FDA approved," and which was a process, mind-boggling process. But we got it approved, and now it's out there for every dentist to use. So what is combination therapy? Well, we're combining two therapeutic devices or modalities. We're combining them to help the patient. And it can be any types of therapies can be combined. But what I'm talking about here in this lecture is combining PAP therapy, CPAP therapy, and oral appliance therapy. So first, what is not combination therapy? These devices shown here are not combination devices. They only connect to the upper arch alone, or they don't connect to any arch. They only go through the mouth or whatever. These are hybrids. They're not combination devices because you have to have oral appliance therapy with the CPAP. None of these advance the mandible like oral appliance therapy does. These are some samples of integrated devices, which I'll talk about later. This is the Fusion Custom Mask. This is the custom mask that I'm able to modify by cutting this part of it off. This is a boutique mask we make we can have, tiger, zebra, camel, pink. And then this is the TapTap CS or chairside device. So I'll talk more about these later. So like I said before, you can combine any two therapies. You can combine old and positional. You can combine surgery with PAP. You can do hypoglossal nerve stim with, all these different devices and combinations are available. But today it's going to be about PAP therapy, positive airway pressure. CPAP is constant positive airway pressure, but you can have BiPAP and others. And combine it with the oral appliance therapy or OAT. I gave a similar lecture, the first one of its kind, back in the mid 2000s at the Academy of Downstate Medicine, and they asked me to present this. And so I think, well, no one's ever presented this before. I think I will call up a few of our colleagues that were doing this and said, how should we define combination therapy? So this is the definition that we came up with. It is a PAP interface to the nose or mouth or both that is either in conjunction with an MAS, that's called dual therapy, or one that connects to the PAP hose directly to an oral appliance, that's called integrated therapy. But they both feature mandibular stabilization. In other words, you get the best of both therapies while reducing the challenges of each. So the benefits that the OAT brings to the therapy is that it stabilizes the mandible. And that's obvious because we are attaching the lower jaw to the upper through the oral device. The other thing that oral appliance therapy brings is the activation of the genius glossus muscle. When you bring the jaw forward, it activates the tongue and makes it stiffer, which helps stabilize the airway. And we also, when you use integrated therapy, we're able to seal the mouth with the oral device. Now, what PAP benefits, what they bring to the combination device, is they stabilize the airway with a positive pressure. The PAP does all the hard work. The oral appliance helps the PAP, but the PAP does the work to stabilize the airway with positive airway pressure to offset that negative pressure, which, by the way, the negative pressure in the airway is the trigger for the protective reflex, which results in clenching. In other words, when the airway collapses, the esophageal pressure drops, and that triggers the brain to clench to help open up the airway. That, with a PAP, is reduced or almost eliminated. So by combining these two, you also reducing the challenges that oral appliance therapy has, which is to reduce the amount required to advance the jaw. We don't need to advance them all the way out to full protrusion. I only advance them about 3 millimeters. And that's enough to accomplish everything the oral appliance needs to accomplish. This puts less stress on the TMJ. And of course, you have less side effects of OAT. Now, it reduces the PAP challenges, and this is what you tell a physician when you talk to them. We're able to reduce the required pressures to keep the airway open. We have less leakage, and we can eliminate the straps. All the studies have shown the most common complaint of PAP therapy is the leakage and the straps. Now we're connecting to the oral appliance directly, and we're getting rid of the leakage. So who gets an oral combination device? Who gets combination therapy? Well, the first indication for combination therapy is oral appliance therapy failure, where it's either the oral appliance is not tolerated by bringing the jaw forward, the patient can't tolerate, or even when you do advance them as much as possible, you still have residual apneic events. In other words, the appliance is not being effective to resolve the situation. So now we have to move into, let's add a CPAP to the situation. Number 2 indication is that you have failure of CPAP. Because if the CPAP worked, you wouldn't need to add an oral appliance to it. So it's kind of obvious. So you have to have failure of both in order to consider combination therapy. So here's the deal. The doctor puts the patient into a CPAP situation because he just got diagnosed, needs a CPAP. Well, first they start with the nasal pillows or nose mask, and the pressure goes into the nose, down the throat, hits that obstruction behind the tongue, and the pressure says, it's easier, let's go out the mouth. So you get leakage out the mouth. So then the physician adds a custom mask. And not a custom mask, I'm sorry, but a full face mask. Well, this seals off the mouth. Or does it? Sometimes the pressure is too much and they have to put leakage on it. You get leakage on the mask, and you start getting the patient taking it off at night because of all the leakage and the noises and stuff. And so then what the doctor does is to add a chin strap to keep the mouth closed, keep the leak from happening. Well, what does this do? This distalizes the mandible, helps to reduce the size of the airway or basically close it down. And so the result is they have to turn the pressures up. So this is a cycle and the fight that they have to try to get the patient to have comfortably breathing at night. So you can see, I'm showing you this so that you can, when you talk to a physician, you understand this is what they're trying to avoid. So there are 2 types of combination therapy. The first one, type 1, is called dual therapy. Basically, we're combining 2 separate therapies, PAP plus the oral appliance, to the same patient at the same time. This is something that you can do Monday morning when you go back to work. Very simple. If you can do oral appliance therapy, you can do dual therapy. So we're stealing We're still stabilizing the mandible. It's easy to implement into your practice. Nothing's changed. No special training. Everything's the same. You're just making an oral device, but you're working with a physician to add the CPAP and to work with the CPAP. This can be used for several reasons. I'll tell you at the end the indications, but basically, let's say you're using an oral device and you bring the jaw forward and you just can't bring it forward enough without the patient becoming very uncomfortable, or you're bringing it forward and you're just not resolving the apnea. You're still getting oxygen desaturations. So then you just add a CPAP. It could be for temporary or it could be more permanent. This is a quick study I did with Dr. Jerry Simmons. He had 10 patients who are ready to drop out or abandon CPAP therapy. He's a physician down in Houston, sleep physician. And they're ready to drop out. He just did a boil and bite, and they stayed in PAP therapy and actually improved. So this is for dual therapy, just a quick little abstract to show statistical improvement. Type 2 is called integrated therapy. And now what we're doing is integrating the PAP therapy and the oral appliance therapy. These are the different devices. They require a device. They require the oral aspect. With the post, you can connect this TAP-PAP CS, or on that post, you take a face impression and do a full face mask or just a partial. When you connect the PAP directly to the MAS, you get superior stability. You're now connecting the whole integrated device to the skull base via the dentition. Very solid. The patient can move his head wherever he wants. It doesn't matter where it is. It's not going to move or shift or leak. So you get rid of the straps as well. The two main reasons why PAP fails from the patient's perspective is the leakage and the straps. So this eliminates both of them. But you need some special training with this device. You have to learn how to take a face impression, which hopefully will change in the future. You need to be familiar with CPAP. Not enough to have to do it, but you have to understand how it works and work with the physician on that. It's more difficult to implement into your practice because I teach this, and what we want is the key assistant to come along, because without a trained assistant to help you with all this particular device, there's very little profit in you doing it all yourself. So you want to have an assistant with you who understands and can help and make it all worthwhile. Insurance is not known. It's not really appropriate. It's for there's insurance for CPAPs, there's insurance for MAS, but when you combine the two, there's not really any codes for that. We're working on that too. So for now, as a dentist, what I use is just the MAS code, because there is an oral device aspect to this mask. So this is a quick little study I did after I did like 10 patients. And I did a survey, and the custom mask was much preferred over a stock mask. But what I didn't put on here was the surprise, which was the bed partner. The bed partner questionnaire came back extremely excited about how they can sleep better now, because the bed partner who's wearing a custom mask is now quiet. He's still, and the bed partner gets a much better sleep now at night too. So that was kind of interesting. I didn't think of that when I did it. So Dr. Thornton invented this system, like I showed you before, and he gave me the exclusive license to teach and fabricate these devices, and that's where the conflict of interest is coming in. But don't worry, there's not many being made. I'm not making much money. I will make zero money off this lecture as far as this conflict of interest goes. But I am uniquely qualified to teach this because this is what I do. And no one else is doing this right now. There's two types of integrated devices. One is called the TAP-PAP CS, or chair side. And we have the oral device with the post. and then this comes out of a bag and connects to the post and tightens down. Very nice for a quick conversion. Your assistant can do it, and you check it and everything, and it doesn't take much extra training to do this. The Fusion Custom Mask is a lot more involved, as you will see in a minute here. We're taking an impression of the face and making a mask that custom fits the face. So the way the system goes is you start here and we finish down, okay? So we can start with one of two devices. You can either take a tap 3 device and screw a post onto it like that, and that'll be your oral device. Or you can make these shells without the tap 3 mechanism and just put the post, attach the post to it. That's called a fusion monoblock. Either way you go, doesn't matter, but you might want to consider if the patient comes to you and wants an oral device, doesn't want a CPAP, but they're more on the severe end, which isn't really indicated for oral devices, but you just want to see if it works, I would try a tap 3 so that you can convert to this later if you have to, without much cost or time. So once you have the oral device fabricated, then the second stage is attaching either a chair side device, like it comes in a bag, or going to the Fusion Custom Mask process. So that's the end. That's how you finish with either of these two devices. So let's talk about the TAP-PAP CS first. Okay. Like I said, it's simple. You have the oral device already made, and then you attach this TAP-PAP CS. It's fully adjustable here. It has an optional headset for the hose, which I think is redundant, but it can go off to the side. It doesn't matter. But it works best for CPAPs with pressures 15 or less. If you go over 15, what starts to happen, you start getting leakage out the side of the oral device, and the lips start vibrating. You get a hoarse sound like that. And so then the patient can't wear it because of all the noise it makes. And plus you're getting the leakage, right? And so if you're considering the CPAP CS, this is the close-up of what it looks like, okay? This is the tap 3 mechanism here, and you're screwing a post onto it, and onto the post comes this device, which is the hose to the CPAP machine. And these are the nasal pillows that go into the nose. If you're just starting from scratch and you want to skip the step of making a tap 3, you just know this patient needs a combination device right now, let's do this. You can just have the monoblock made with a post, and then you get it back and you open up the bag, put this on there, and off they go. This does not require any extra training, and this is something that you can start Monday morning. You can start by either getting a monoblock made or tap 3 made. Now, let's say your pressures are high, or the patient doesn't like the nasal pillows, or the thing just isn't working. Then what do you do? Well, then you go to the next step, which is to start out with the oral device, either a monoblock or a tap 3 like we did with the other one, except this time we're going to connect them together. Now, we lute these together with thermocryl, which can be adjusted. I always lute together these devices for the TAP-PAP CS as well, although that can be optional. So that's part of what you learn when you learn these systems. For the CS, you can either leave them apart or you can put them together. I recommend putting them together because we're getting good mandibular stabilization that way. And then we take that device, put it in the mouth. This is the one with the tap in there. And the post is sticking out, and we take an impression of the face. And if you want to do this, you learn. I can teach you. I don't know if I'm going to give them more courses or not because we're going to try to go digital. But we put, plug up the nose. We put a breathing tube in there so they can breathe while we take the impression. And we put PVS, polyvinyl siloxane, light body. And then we take this disc here. This is a thermocryl disc. You warm it up and it molds like that. Then you fill it with heavy body PVS. And you push it down on there, and it captures the lower one on the face, and you pull it off, and there's the exact impression of the face. I had this published back in 2016 at the Journal of Prosthetic Dentistry. But this is what you have to learn in order to take a face impression. Then that goes to lab, and what I do is I pour up a plaster model of that. There's the transfer post. I use a BioAcryl machine, BioStar rather, and I make this in 2 different stages, and ends up looking just like this. This is the blue net embedded in thermocryl, so you can heat this up and change the angulation of the mask if you have to. Attach the oral device, and there's your custom mask. We've got studies on it. It can tolerate high pressures. Dr. Thornton was using them for 65 centimeter water pressures. You can modify the airflow. In other words, the airflow right now comes up, the pressure comes up the hose into the nose. This is sealed off here. And so it comes on here and tries to come out the mouth. It's sealed. This is sealed. Instead, the pressure goes back through the nose and back out. These are export holes. So let's say the patient has nasal issues, septal deviations, sinus. I have other stories, but basically we had to guide the pressure. I break a hole through the plate here, and we guide the pressure into the mouth. So now we can guide the pressure into the mouth and the nose. For mouth breathers, this is much more comfortable. But we had the ability to do that with this mask. And of course, we end up lowering the pressures because we're augmenting the treatment with advancing the mandible. So who gets a custom mask? I did a study with a sleep physician, a friend of mine, Dr. Swick, and we did a retrospective study on 75 patients who got the custom mask. What we found is that most of the patients with custom masks were CPAP intolerant. They came right from CPAP into this device. These pressures were able to be reduced. Long-term compliance, we had some over 10 years old. And we also figured out the cost effectiveness was that it was less costly than the slot mask because they last for 10 years. So we took the 75 patients and I determined where they came from. In other words, 15% of these patients here, before they had a custom mask, they're in OAT monotherapy with a TAP3. In other words, the OAT failed, and they did not want to go to the nasal pillows. They want to go directly to the CPAP or the custom mask. So that was only 15% of the custom mask patients came out of OAT. Close to 30%, we tried the nasal pillows first, TAP CS, and they didn't, the pressures were too high usually, and so they had to go into a custom mask. But majority, 60% of the patients who were given a custom mask came directly from CPAP monotherapy. In other words, they were the more severe end of things. Their pressures were high, they had significant comorbidities. If a patient has heart problems and they're in high pressure CPAP, you don't say, hey, let's try a oral appliance first. No, you get them right into the best of the best, which is the custom mask. That never fails. It works every time. So the conclusion of my study was that the application of a custom face mask is for patients with more severe OSA and is well tolerated with improved compliance. I only had, out of 75 patients, if I remember right, I only had 2 people drop out. One was a patient with dentures. We tried to make it work, but he couldn't. The other one went on to bariatric surgery and then didn't need it anymore. So it's very well, compliance is extremely high on these custom masks. So this is a story of Ricky. Ricky is one of those I call my heart patients or my heart and soul patients. And I know you all have them. They're the ones who you see with a huge need that you think you can help. And in his case, you don't care if you get paid or not. I didn't care if he paid me. He's a Navy veteran who washed out because they could not keep his airway open. He served in the Navy for 10 years, and his apnea got worse, and they couldn't control it. And at age 45, or age 40 rather, they discharged him because they couldn't keep his airway open. BMI was 40, RDI was 70. His oxygen went down to 66% at night. He was on a BiPAP that really wasn't working. 26 centimeter water pressure in and 20 out. And that's really high. And it was leaking like crazy and not working. So the lab called, and that's usually never a good situation when they call me at night. And they say, hey, we got this patient here. We can't stabilize with a BiPAP. Could you come over and help us? And so open up his mouth, and that's what I saw. Went, oh my gosh, I see the problem. Look at him with his tongue. He has a very severe medical disease called BFT, and that stands for big fat tongue. There was no room to breathe there at all. And so I was able to make a boil and bite. We advanced his mandible, and that helped stabilize the BiPAP. And I said, you need to get to my office tomorrow. So he came in. We took a CT. That's the size of his airway, or ICAT rather, size of a coffee straw. That's sitting up wide awake. You can imagine when that tongue falls back what it looks like. He was on 24-hour oxygen. He was having organ failure. He was on polypharmacy. He was too sick for surgery. They couldn't do surgery on him if he wanted to. And his BiPAP wasn't working. And so I thought, like any good dentist doing sleep medicine, I'll start with an oral appliance. So we did the tap, and look at that. It just basically made things worse. It was a total failure. And so we had to go into integrated therapy. And look at him, his eyes. I mean, he's exhausted. I'll never forget when he first came in, his wife was Japanese. She was so worried about him and crying, said, please help Ricky. He can't sleep and he's going to die and no one can help him. And I said, I'll try. And so he couldn't tolerate the full mask because his nerves are so jazzed up from protecting his breathing that he just couldn't tolerate the full mask there. So I made him this nasal, I made him a full mask, cut it off so the nasal part still worked. The oral appliance was able to seal his mouth to help his high pressures, and that he was able to do. Okay, so no more leakage. So we took him and sent him downtown, Houston, downtown medical center there, and they did orthodontic surgery, which they had to do some studies first because they thought it was acromegaly, and it turned out to be Beckwith-Wyndham syndrome, which fascinated them because that's basically a childhood disease. He's the oldest person on record to ever have this. So they took out 60% of the genius glossus muscle. The mandibular advanced his mandible 11 millimeters and his maxillary 16. So he came back to my office and we did another ICAT. And look at the difference. We went from that to that. Sagittal view, there to there. This is still very small, right? And he's still sitting up, awake. But now, at least, we were able to get him into a full mask. Look at how bright his eyes are. He's lost weight since this picture. This is the trach. They had to trach him because the surgery itself swelled up it just completely cut off his air breathing there. And we took the trach out shortly after we made this, but we made him a full mask. He was able to tolerate it. And he just loved this thing. He took it, all his appointments, all his doctors to show him. But here's the most important thing. By offering combination therapy, we were able to give them hope and ease of mind. Breathing is on the top of the hierarchy of needs, and when it's being threatened, the body will do whatever it can to breathe, and that's what his body is trying to do. And it was shutting down, and he was losing hope. He was losing his will for life, and we were able to help him just by stabilizing the area with this combination device, which there's nothing else that would have helped. We tried oral appliance therapy, they tried PAP, nothing was saving his life, but this did. And this is something that you will experience the more you do these things, the more you do combination therapy. Just do the dual therapy, you're going to be making huge differences in people's lives like you won't believe, and those around them. So what is the future of combination therapy? Well, type 1 dual therapy can be implemented today. You can do it Monday morning, simple. But we need to get more dentists and sleep physicians aware of the benefit of doing this. And this is why I am, passionate about teaching this, because it helps the patient, it helps the dentist to grow his practice, it helps the physician keep their patients healthy. It's a win-win for everybody. But we need more research validation so that we can prove its effectiveness. Integrated therapy has a different future. We need to learn and practice more. It needs a stronger relationship with physicians, so we need to work more on that. It needs more development, which I'm going to talk to you about in a minute. And it needs much more research validation. I did my paper, and it's the only one of a kind about this device. And of course, there are profit issues because it's very labor intensive. The lab costs are there, and so that needs to be reduced, and that will come with more development. Which is, this is a picture of my wife, and we were in a bar, and I have this app on my phone called Trino, and I took a 3D picture of her face in the bar. That white was a car driving by, flashing reflection of the sun. But you can take that image, upload it, and they can convert it to an STL file and put into the program called Mix Mesh, and it can make a mesh of the face in which we can build an oral face mask on top of that and then 3D print it. And that's where the technology is going. We have the technology for each of those steps, right? So I've talked to companies about it, and it's going to cost $250,000 just to integrate this into a chain and to make it work. So right now that's too much. I'm hoping the technology costs will go down as everything does, and we can get this into the digital age. I don't think the custom mask will be a mainstream treatment option until we're able to do this. We're just going to have to rely on non-custom options that are available. But this is what I'm hoping for. So when do you consider what to do? Well, consider dual therapy as a temporary treatment to settle an unstable airway. In other words, if you're bringing the jaw forward and the patient's increasing clenching, TMJ, and headaches, and just can't tolerate it, send back to the physician and say, I'd like to add a CPAP to this temporarily. And put them back in the CPAP with the oral device, titrate the oral device while they're on CPAP, much more comfortable experience, and then get them off the off the CPAP, and you're back to the oral device. Or it may be a permanent solution when your oral device alone can't accomplish therapeutic goals. In other words, if you advance as far as you can and there's still desaturation in the blood with the oxygen, so then you say, well, I guess we tried our best, you need to go back to CPAP. Well, no, you don't. You can just add a CPAP to this. It'd be a much better experience, because the patient will say, I don't want to go back to CPAP, I hated it. But now you tell them, we have an oral device that fits, it's working, let's go back to CPAP. It'll be lower pressures, much more comfortable. Maybe all you need is a little nasal pillow, and the oral device will be more comfortable because we can back it off a little bit, and it's a great permanent solution to the patient as well. When would you consider integrated therapy? Well, that would be for the patients who are more severe, right? And so that patient had to fail oral appliance therapy, And like my study showed, these are usually the patients on the more severe end with a lot more comorbidities. So this is a solution to their CPAP intolerant cases. The physicians would love to have you doing this. They understand it, and they know that you will be helping their patients significantly. Consider using combination therapy to build bridges to your MD referrals. See, what you're doing is you're helping the physician keep their patients in PAP therapy. That's a refreshing point of view. I mean, what other dentists would they ever hear that from? Usually dentists will say, I hate CPAP club and I use oral appliances because you hate CPAP. PAP isn't very good. Yes, PAP is great. But it's an essential therapy, especially for people who are more severe. Oral appliance doesn't solve all the problems. We can help the physicians solve their mask problems. We can help them solve the high pressure, the compliance, and the intolerance issues. We can always help the physician. Now you're using this, you take this combination device, show your physician what you're doing, or you take the literature that you can get or this slideshow and say, look, I'm doing these. I'm just adding oral appliance to your CPAP. Let me help you with your CPAP patients. 3 secrets to collaboration with sleep physician: communicate, communicate, communicate. Tell them, let me help you keep your patients in PAP therapy and see what happens next. You will start getting all the referrals. You'll be doing oral appliance therapy, monotherapy all day long. But when a physician and a dentist collaborates, nothing is better than the success that comes from that collaboration than seeing the patients being treated. They're being treated, they're going to have a better life. You have more satisfaction, you have a partner, and you're able to do combination therapy at the highest level possible. And who's going to benefit? Number 1, the patient. Number 2, you. Your practice is going to flourish and your practice is going to grow. And the physician is going to be happy and he's going to be referring you more patients. Believe me, I know about collaboration. This is my grandfather back in the 50s with his brother. He's a dentist and his brother was a physician. So you can imagine, Christmas dinners between those two. But now we have my brother who's a dentist, me, dentist, my other brother's an ENT surgeon, and my father, who recently passed, was a dentist as well. And so, family dinners were just crazy, arguing, but we learned a lot about collaboration, believe me, and I really encourage you to do the same. So thank you for your attention. Thank you for listening to this and considering it for your future practice needs. And you will be extremely happy with the results. And I wish you the best in your journey.